great to be here, and I would like to leave as much time as possible for questions. I also want to apologize for those of you who were in the previous session where I presented earlier this morning about combined immunodeficiency. You may have seen that I've slightly modified the title here because, in fact, autoimmune issues we often see in patients with CID. We may see in patients with atypical SCID. We don't really see those in patients with typical SCID. But again, apologizing for those of you who have listened to my previous talk, I will start by repeating some of the slides I presented previously, which are the definition of SCID, atypical SCID, and CID, because that are very helpful to set up the stage for what I'm going to tell. So I will focus on the mechanisms of immune dysregulation, why that can happen in patients with atypical severe combined immunodeficiency or combined immunodeficiency. I will review with you the clinical manifestations, the laboratory correlates, what treatment options we have, and more importantly, I'd like to leave time for questions and hopefully answers. So the Primary Immunodeficiency Treatment Consortium has developed criteria to distinguish between typical forms of SCID, atypical SCID, and Omenn syndrome. And again, this is important because, as I mentioned before, we do find immune dysregulation quite frequently in patients with atypical SCID. We don't really see it in patients with SCID. There are also differences related to the requirement for conditioning in patients with atypical SCID and Omenn syndrome versus patients with SCID. But this definition of typical and atypical SCID is largely based on the number of T cells that are present. So these are that should not be CD3 cells per ml but per microliter. The number of these T cells is less than 300 T cells in patients with SCID. You may see in brackets there autologous, because you may have also maternal T cells present in patients with typical SCID. If that happens, that actually is a sign of typical SCID. You also find SCID-causing mutations as another supporting feature. The T cells in patients with typical SCID are not only extremely low or absent in number, they also are extremely poorly functioning. And this is shown by proliferation to a mitogen, which we use in a lab to make T cells proliferate. So these patients' T cells are virtually incapable of undergoing proliferation. In fact, we find responses that are 10% of the lower limit of normal. I want you to contrast this with atypical SCID, because this is actually where we do see immune dysregulation relatively frequently. So these patients have a slightly higher number of T cells, although they are still lower than the normal number of T cells at that time, at age, in newborns. And more importantly, what you find in their T cells is that they don't express markers of cells that have just been produced in the thymus, which we call naive T cells. They tend to have more of what you find a memory-activated phenotype. So when you receive actually results of flow cytometry, you may find the CD45RA as a marker on naive T cells, often in combination with other markers, but sometimes just 45RA. And you will find that the memory or activated T cells are RA negative. So in a newborn, you want to have many RA positive, 45RA positive T cells. Those are naive T cells. In patients with atypical SCID, you have actually an increase in the activated or memory T cells. Those T cells are not only present in slightly higher numbers than in patients with typical SCID, but they also have a slightly less profound defect in T cell proliferation. In fact, the T cells can mount a proliferative response which is somewhere between 10 and 50% of lower limit of normal. And typically what you find is that they carry mutations in the same genes, the SCID-associated genes, but these mutations are permissive for some protein expression or function. Omenn syndrome is a very typical and different picture where you have generalized skin rash. You do have quite a number of T cells. These are patient's own T cells, but they are very restricted in their diversity of the repertoire, so they only recognize few pathogens, few antigens. Their proliferative response can be variable, again, more in the range of the atypical SCID. And they also have other features like an increased number of eosinophils. They often have enlarged lymph nodes, big spleen, large liver, and elevated IgE. Now, in contrast to this, the European Society for Immune Deficiency has defined diagnostic criteria for combined immunodeficiency. And so along with the atypical SCID, this is the other situation where we find quite frequently immune dysregulation. And these are the criteria, so they are significantly different than the ones that the PIDTC has developed for typical and atypical SCID. First of all, you will see that they start actually with clinical features. So according to ESID, you need to have at least one of those three features, either one severe infection requiring hospitalization, at least one manifestation of immune dysregulation or affected family members be present. And immune dysregulation can come in many flavors. You can have autoimmunity, which again by itself can be extremely heterogeneous, or you may have inflammatory bowel disease, or severe eczema, or lymphoproliferation manifesting as, again, a big spleen, big lymph nodes, large liver, or granulomas. And then on top of that, at least one of those, and then 2 of 4 of T-cell criteria, which are similar to those that I showed you that a PIDTC has developed for the typical and atypical SCID. So reduced T-cell number, but in this case not just CD3, can also be just CD4 or CD8 or CD8 positive T-cells, lower than normal. Reduced number of the newly generated T-cells, naive CD4 and CD8, elevated number of T-cells that express one specific type of T-cell receptor, gamma delta, that typically is only present in 10 to 15% of peripheral T-cells. It can be much higher than that in patients with combined immunodeficiency. And again, reduced function of those T-cells as measured by reduced proliferation to mitogens. You need to exclude HIV infection. And you need to exclude other diagnoses which are also associated with combined immunodeficiency, but they are represented by very unique features that define individual syndromic situations like ataxia telangiectasia, cartilage hypoplasia, where you have short stature, a tendency to bone marrow failure, Hirschsprung disease, dyskeratosis congenita, which manifests often with, again, anemia, thrombocytopenia, and other skin and mucosa manifestations. So again, we're talking about a spectrum of phenotypes that ranges from the typical forms of SCID on the left to Omenn syndrome, atypical SCID, and CID. The important point I want to make is that this can happen for mutations that in the same gene, so different mutations may lead to all of these phenotypes. And the clinical manifestations are different depending on the type of disease or type of the phenotype that you're having. So if you have a typical form of SCID, what really is the hallmark from a clinical standpoint is infections. And unfortunately, these infants have very severe infections early in life. With newborn screening now, we're able to identify them properly and prevent as much as we can infections and refer them to bone marrow transplant as soon as possible. With patients with CID and the atypical SCID, you see we are in a situation where the clinical manifestations actually is a mixture of infection and autoimmunity, and autoimmunity actually even may prevail in some of these patients, especially in those with CID. So we're talking about a different kind of clinical presentation. Also, what happens in the patients with CID and atypical SCID is that they are more prone to malignancies, especially lymphomas, but not only lymphomas, which is something we don't really see very much in patients with SCID and Omenn syndrome. So, again, just to reiterate one more time, you may have defect in the same gene resulting in very different phenotypes. So different mutations may sustain different phenotypes. And one example of this would be recombinase activating gene defects. Now let me talk about the immune dysregulation, because this is really the core of my presentation. So until 20 years ago, we used to think that immunological competence would be a situation where our immune system would be able to cope with infections, and so allow us to mount good antibody responses, good T-cell responses against pathogens that would prevent serious infections. At the same time, the immune system would mediate surveillance against tumors, so we would not catch tumors until the immune system perhaps decline with time, and then we would be more prone to these kind of problems. And the immune system would also be able to prevent autoimmune manifestations. So if you had too little of the immune system, then you would have a situation where you may have immunodeficiency manifesting as infections or an increased frequency of neoplastic situations. And on the other end of the spectrum, a too active immune system would lead to autoimmunity. So this view of the immunological competence would be such that autoimmunity and immunodeficiency would really be at the opposite ends of the spectrum, and you could not have together at the same time infections and autoimmunity in the same situations. But we learned that this is absolutely wrong. This view of the immune system is wrong, and we recognize that by studying, in fact, patients with immunodeficiency, and in particular patients with atypical SCID and combined immunodeficiencies. So what are the mechanisms why in patients with atypical SCID or combined immunodeficiency you may have immune dysregulation? Well, one mechanism is the inability to clear the infections. So whenever you have a persistent infection and the immune system has some function, the immune system may recognize that there is something wrong, something that should not be there, a pathogen, a virus, typically a virus more often, but sometimes, fungi or bacteria, and that would lead to inflammation. Inflammation is, in fact, one potential manifestation of the immune dysregulation. This is especially true, as I mentioned, for viruses, and it is especially true for some viruses that tend to persist or recur many times in the history of any of us. A few examples there. Herpes simplex infection, which is an infection that we all catch in life. In patients with these problems, with combined immunodeficiency, that would result in chronic recurrent reactivation of the herpes simplex, and that may lead actually to enhanced inflammation. Cytomegalovirus, a CMV, also a virus that most of us actually catch at some point in life. In patients with combined immunodeficiency, tends to reactivate, and that may lead also to not only infections due to the CMV, but also may trigger autoimmunity. And a typical manifestations of autoimmunity associated with CMV reactivation is autoimmune hemolytic anemia, very common in patients who have a reactivation of CMV. Epstein-Barr virus, EBV, the virus responsible for mononucleosis, mono. So in these individuals, the EBV, again, which is another virus that normally establishes latency in all of us, would periodically reactivate or may lead even to chronic and persistent viremia. But quite often this situation is associated with lymphoproliferation. So again, these patients may develop a big spleen, big lymph nodes. Autoimmunity, again, especially cytopenias, but also liver inflammation. And the varicella-zoster virus, which is another herpes virus, also establishes latency after a single episode of chickenpox or after immunization with the varicella vaccine. But in individuals with atypical SCID or combined immunodeficiency, if they catch a varicella virus, or even if they're immunized with a live varicella vaccine, that virus, although the varicella virus vaccine is attenuated, it may actually reactivate. It may lead to serious complications either at the time of the immunization or later on in life and manifest as shingles or other serious manifestations of varicella. So the persistent immune activation that is associated with chronic presence of these viruses actually also leads to enhanced cell death. And when you have cell death in the body, that actually is a trigger for autoimmunity. So the persistence of cells that undergo death is a stimulus for the immune system to mount inappropriate responses manifesting autoimmunity. You have also another major reason why patients with atypical SCID or combined immunodeficiency may develop autoimmunity, and that is actually defects in checkpoints of immune tolerance that we all have for both T cells and B cells. I want to very briefly explain what do I mean by that. So we all produce T cells in the thymus, and we produce lots of these T cells. Actually, the repertoire in the thymus, so repertoire means T cells that recognize different antigens, different pathogens, is extremely high, 10 to the 11. So 10 to the 11 different types of T cells. That's a pre-immune repertoire. Then by a mechanism of positive selection, you only select T cells that eventually will be exported to the periphery. We call them naive T cells. Now, because the process of generating T cells with a defined repertoire, defined capacity to recognize antigens and pathogens happens randomly, you can also generate T cells that are actually randomly capable of recognizing self-antigens. So they would be able to recognize, for instance, insulin or liver cells or something like that. You don't want those cells around because those cells are self-reactive. So they could mount a wrong immune response against your own cells. So those autoreactive T cells, most of them, are actually deleted in the thymus by a mechanism called negative selection. So in the thymus, we try to remove as many as possible of those autoreactive T cells. We also generate one type of T cells which are called regulatory T cells, and I'll show you in a minute what those cells are. So once the thymus generates naive T cells, regular T cells, and very few autoreactive T cells escape this mechanism of negative selection, then what happens? Well, the naive T cells are exported to the periphery. They form the vast majority of T cells that we have around. Some of these T cells will encounter, let's say, a pathogen, and they will help us mount a memory response so that the next time that we encounter the same pathogen, the immune system will be capable of recognizing and fighting that infection more promptly. So these are the memory T cells. I mentioned there are few autoreactive T cells that actually escape the mechanism of negative selection. So we do have those autoreactive T cells normally around. In order to control them, that's exactly what the Tregs do. So the Tregs control the response of autoreactive T cells. So we need all of this system to be in place in order to, on the one hand, being capable of recognizing non-self antigens, those are the naive T cells and the memory T cells, and suppressing responses against self-antigens, the ones that mediate autoimmunity. In patients with atypical SCID and combined immunodeficiencies, many of these mechanisms go wrong. So on the one hand, you generate fewer cells that are capable of recognizing non-self antigens. On the other hand, the mechanisms that actually normally suppress generation of autoreactive T cells or control of autoreactive T cells are also wrong, and you have more autoimmunity. And the number of T cells that we have, of course, is much less than what we generate in the thymus. We also have mechanisms that control autoreactivity in the B cell compartment. So B cells are produced in the bone marrow. You have B cell progenitors. B cell progenitors, we all produce B cell progenitors that contain many B cells who express immunoglobulins that recognize self-antigens. So we all produce in the bone marrow a population of cells that, in theory, would result in an autoimmune response. Very much by a similar mechanism of immune tolerance in the bone marrow, we change the capacity of those B cells to recognize these self-antigens. We call this receptor editing. So they change their immunoglobulins. That immunoglobulin no longer recognizes the self-antigen. It's now capable of recognizing a non-self-antigen. By this mechanism, from B cell progenitors to immature B cells, we decrease the percentage of B cells that recognize self-antigens. That is good to protect against autoimmune responses. Those immature B cells are exported to the periphery. They are transitional B cells. The one in brown here still depict autoreactive B cells. And we have mechanisms actually to further deplete the proportion of autoreactive B cells from transitional B cells to mature B cells so that really the mature B cells that are around contain just a few autoreactive B cells. We have other mechanisms that control those autoreactive B cells, again regular T cells. There is also a new category of regular B cells that have been identified. So these are cells that actually suppress autoreactive immune responses. And complement also plays an important role in preventing autoimmune manifestations. And in fact, many situations where you have complement deficiencies also are characterized by autoimmunity. So again, in patients with CID or atypical SCID, many of these mechanisms may go wrong, and you may have at the same time less B cells capable of producing antibodies to fight infections, but also you have more B cells capable of actually producing autoantibodies. That's not what you want. Just to give you an idea how frequent is immune dysregulation in patients with combined immunodeficiency, the group at Necker, Alan Fisher, published a couple of years ago this paper where he looked at his cohort of patients and analyzed actually the proportion of patients with CID that do manifest immune dysregulation in the form of inflammation, autoimmunity, during life. What you can see is the proportion of patients with CID that manifest immune dysregulation is actually pretty high. 50% of these patients with combined immunodeficiency will manifest immune dysregulation during their life. Not only that, this immune dysregulation happens also in the first years of life. So by year 20, approximately 1/3 of these patients have already manifested some autoimmunity. So autoimmunity is not a rare complication in combined immunodeficiencies. The events actually that lead these patients to hospitalization, and this is another study from Germany in patients with profound combined immunodeficiency, can in fact be both infections and autoimmunity. This is so on average, each patient in this study experienced one hospitalization or a bit more than one hospitalization per year. And as you can see in blue is the reason for hospitalization due to autoimmunity, either cytopenias or other kind of autoimmunity. And 50% were hospitalized because of infection. So you have an equal burden of infection and autoimmunity really in this patient population. Again, to make the point that immune dysregulation is very important in these patients. I mentioned that you can have anything from SCID to autoimmunity, even in the presence of defects in the same gene, and the best example of this, I think, is RAG deficiency in humans. I mentioned that it's actually a mixture of infection and autoimmunity in this situation. And so this is a study that exemplifies what type of autoimmunity and when can we see autoimmunity in patients with RAG mutations. This is a multi-center study, but you can take this as an example of what happens in any kind of combined immunodeficiency. The number for RAGs are higher because RAG is relatively common as a reason for combined immunodeficiency. So there were 63 patients with RAG mutations and manifestations of immune dysregulation in this study. They were divided according to phenotype, and you will see that in green, only 4 were the patients with SCID that manifested immune dysregulation. So the real problem of immune dysregulation happens in patients, let me go back one slide here, at the very end, on the very right of this spectrum, the leakiest mutations, those that are associated with granuloma formation, autoimmunity, delayed onset disease, variable number of T and B cells around, clearly a more subtle phenotype than the typical lack of T and B cells that you see in RAG patients. That's a CID-GI. The other big group was in red, the atypical SCID. So again, those are the two situations, atypical SCID and combined immunodeficiency, where you may see immune dysregulation. What type of immune dysregulation was seen in these 63 patients? Well, it's interesting that over 80% of them experienced at least one episode of severe autoimmune cytopenia. Autoimmune cytopenia means autoimmune-mediated anemia or autoimmune thrombocytopenia. Your platelet goes down. It's less easy to diagnose autoimmune neutropenia. So autoimmune hemolytic anemia and autoimmune thrombocytopenia are clearly more common. So over 80% of these patients had this problem. The other manifestations of immune dysregulations were granulomas that may affect any part of the body. They're more common, I will show in a minute, in the skin, but they can really affect any organ. But you can see that otherwise, the spectrum of autoimmunity can be extremely broad. Some patients had vasculitis, in some cases very severe. Others had gut problems, enteropathy with chronic diarrhea. They were biopsied. They looked like Crohn's disease. It was not really Crohn. It's this kind of immune dysregulation. Some had neurological problems. Hypothyroidism is very common in this situation. Some had a big spleen or autoimmune hepatitis, even myopathy, nephropathy, uveitis. The important point is that this situation may be difficult to diagnose. Some of these patients may escape diagnosis by newborn screening simply because they produce enough T cells that they may not be recognized by the newborn screening looking at TRAC levels. And so, in fact, in this study, they came to clinical diagnosis before they actually were referred, of course, to transplant, and transplant took 2 years, 3 years after clinical diagnosis to happen. But the molecular diagnosis happened even later. So they were recognized to have a gene defect after receiving bone marrow transplantation in many cases. That's a real problem with patients with CID. I think now we can do much better than this. This, again, is a retrospective study. It is very important that these patients be properly referred and properly genetically investigated. We now have tools to diagnose many of these conditions by genetic testing, whole exome sequencing. And unfortunately, if you don't do that and you wait too long, then a significant proportion of these went to transplant too late, and the mortality was high. But again, this is historical data. I want to tell you that we can do much better than this now. A few words about the autoimmune cytopenias, because they're common in RAG deficiency, but they're common in general in patients with atypical SCID and combined immunodeficiency. I mentioned autoimmune hemolytic anemia, AIHA, autoimmune thrombocytopenia, ITP, autoimmune neutropenia, AN. And you can see that many patients actually had more than one type of cytopenia. So the thing that happens in this disease is that you may have multiple episodes and not necessarily always the same blood cell type is involved. You can have one time autoimmune hemolytic anemia, another time ITP. Quite often, these present early in life. You see the mean age of presentation of these was around 2 years, 2.5 years, in a vast majority of the patients. So they are early onset autoimmune cytopenias, which is another good thing because actually there was a more recent study that showed that if you have Evans syndrome, which is the association of at least 2 cytopenias in a pediatric age, that should prompt genetic tests because most of the times actually you will find a genetic defect. It may be RAG, it may be something else, but quite often actually pediatric Evans syndrome is associated with a single gene defect, and quite often it is a combined immunodeficiency. These autoimmune cytopenias are very difficult to treat, and unfortunately, this is a lesson that we learned by looking at this series. So typically, one would use high-dose intravenous immunoglobulin and steroids to treat autoimmune hemolytic anemia and also ITP, but you see that only 20-23% of the patients responded to this first line of treatment. So in many cases, the physicians had to use alternative drugs. And one drug that you may have heard about is rituximab that kills the B cells because B cells make these autoantibodies. So that's definitely a possibility, and sometimes it is indeed effective. There are other drugs that suppress T cells. We're going to go through them briefly. And there are new drugs that are coming to the market. However, these patients will often tend to relapse at some point. If you don't fix their immune problem, they will tend to relapse. They may have other episodes of autoimmune cytopenia, and only the transplant really fixes the problem in these cases. So again, recognizing properly these conditions is important. The granulomas, I mentioned, may affect any part of the body. You see here 2 examples of skin granulomas. But quite often, you may have also lung involvement, liver involvement. And in many patients, actually have multi-organ involvement, so not just one side. Again, also these granulomas may be associated with frank autoantibody-mediated processes. Many autoantibodies on the right of the slide may be present in these individuals. They may or may not be there, but many patients do have autoantibodies. And like the autoimmune cytopenias, it is extremely difficult to treat these granulomas. To be honest with you, virtually none of these treatments that have been tried in this series really worked, and the only thing that eventually eliminated granulomas was truly the transplant. So you need to fix the immune system to resolve this situation. So how do we evaluate cytopenias in combined immunodeficiency? Well, there may be many reasons why not everything is autoantibody mediated. So there are really 3 reasons for having cytopenias in a patient with combined immunodeficiency. And 2 of them are more common than the other one. So the 2 most common are destruction, autoantibody-mediated destruction of the red cells or the platelets. The other possibility is sequestration. I mentioned that many of these patients have a large spleen. The spleen may trap the red cells, may trap the platelets, and so you have a low red cell count, you have a low platelet count because all of the cells are trapped there. More rarely, much more rarely, you have a problem in the production of the red cells or the platelets in the bone marrow. That's poor production. So to look at destruction, we use simple blood tests, which probably you're familiar with. And there are different types of tests to look at autoimmune hemolytic anemia, thrombocytopenia, or neutropenia. I should point out that the tests we have available for autoimmune thrombocytopenia and neutropenia are less good than the tests we have available to properly diagnose an autoimmune hemolytic anemia. It's very easy to diagnose an autoimmune hemolytic anemia, less so to diagnose an ITP or an autoimmune neutropenia. For sequestration, well, you may think of sequestration when you have a big spleen. When a spleen actually comes into the pelvis, as in this case, well, that's a big spleen. A big spleen sets actually the stage for sequestration. These patients often have a lower than normal number of red cells, and particularly platelets and neutrophils as well. So there are ways to diagnose these: ultrasound, CT, MRI. I would suggest to do, of course, a less invasive, but quite often these patients do require a CT. And it is important to distinguish between lymphoproliferation, benign lymphoproliferation, and a neoplastic process, because I mentioned these patients are also a little bit more prone to tumors. Poor production requires a bone marrow bone marrow biopsy. We tend to do this when actually the other causes of cytopenias are not obvious. So not in every single case you would do a bone marrow. And there are many reasons why the bone marrow may not produce enough of these cells. You may have an infection that suppresses the bone marrow. You may really are experiencing a bone marrow failure, or occasionally you may have a tumor that is invading the bone marrow, and that results also in a poor production of red cells, neutrophils, and platelets. So keep in mind that systemic infection, sepsis, which may happen in patients with combined immunodeficiency, may cause all of the three mechanisms, and even all three at once. So that is obviously a complex situation, and infections have always to be ruled out in these patients. So how do we manage immune dysregulation? We monitor for these viruses that I mentioned, EBV, CMV, not by antibody detection, but by serology, but really by looking at the presence of the virus, viremia, by PCR. We look for warts, which is something that happens quite frequently in patients with combined immunodeficiency. We look for the appearance of shingles. For autoimmunity, we diagnose anemia, of course, by looking at pallor. Patients who have ITP will develop petechia. Patients with low neutrophils will have mouth sores. Vasculitis is obviously a sign of autoimmunity. I mentioned that autoimmune hypothyroidism is very common, and so we look for thyroid function, presence of thyroid hormone levels, the stimulating hormone of the thyroid, as well as autoantibodies to the thyroid. Lymphoproliferation by physical examination, looking at the spleen, lymph nodes, and liver, but also proper imaging studies. Keep in mind, lymphoproliferation does not mean cancer. Many of these patients have lymphoproliferation. You do need to rule out cancer, but lymphoproliferation most of the times is not cancer in these conditions. And granulomas, physical imaging, biopsies, cultures, you always have to think that granulomas might be infectious, so it's important to rule that out. How do we treat them? Autoimmune hemolytic anemia, I mentioned. The key therapy is intravenous steroids, and high doses may be needed. Now you may think, why do I give steroids in a patient that has a combined immunodeficiency? Because at that time, it's the anemia that is life-threatening. You need to treat the anemia. You need to kill those cells that are producing these bad autoantibodies, and steroids is what they do it. Intravenous immunoglobulins are also used, less good than IV steroids in autoimmune hemolytic anemia. Red blood cell transfusions, of course, if needed. Of course, these have to be matched to the donor type. If there are recurrent or treatment refractory episodes, then you may use T-cell targeted therapy, and I listed a few of them. Rituximab to kill the B cells. There are other ways to kill plasma cells other than killing just the B cells. Bortezomib, some of you may have heard about this. The group actually at UCSF has successfully used daratumumab, which is another monoclonal antibody that kills plasma cells. So there are new drugs that are coming to the market and that we are actually experiencing are helpful in many cases of treatment refractory autoimmune hemolytic anemia. Splenectomy should really be reserved to the intractable cases. This is true for all kinds of autoimmune episodes. And consider transplantation, especially if you have recurrent serious episodes of autoimmune hemolytic anemia. For ITP, high-dose intravenous immunoglobulins are actually the key kind of treatment. Steroids are also helpful. Platelet transfusions, if actually you have a very severe drop in the platelet count, less than 10K, or if you have actually serious hemorrhages. Again, you may add additional drugs listed there, very much the same. You always try to target either the T cells or the B cells or the plasma cells. Same caution about splenectomy, and again, same argument about transplant. So the treatment of cytopenias due to sequestration is different. In this case, what we try to do is actually use T-cell targeted therapy. And so all of these are actually drugs that try to suppress T-cell responses. And the T-cells are overly proliferating in these patients, leading to this enlarged spleen. So we use drugs that actually suppress the T-cells so they don't proliferate that much. Sirolimus is one. For those patients who have CTLA-4 deficiency, there may be some here. Abatacept has been used alone or in combination with sirolimus. Steroids are often effective, and again, splenectomy should be reserved to intractable cases because splenectomy, every time you do it, you create room for potential serious side effects, including serious life-threatening infections. Keep in mind that if you are considering transplant And if you have a very big spleen, well, the big spleen is a problem for transplant because not only it traps the red cells and the platelets, but you also trap the stem cells of the donor if you are actually considering transplantation. So that is a situation that has to be discussed very carefully with the transplanter. Some transplanters would like to do partial splenectomy, which can be done by embolizing the spleen. Others may even advocate for a real splenectomy before transplant, or you may decide not to transplant at all. Transplanting with a massive splenomegaly has high chance of actually failing the transplant just because the stem cells will be trapped there. Finally, in terms of other autoimmune manifestations, beyond the cytopenias, steroids, steroid-sparing agents, again, T-cell targeted therapy, B-cell targeted agents like rituximab or plasma cell targeted agent like bortezomib. In this situation, high-dose IVIG are rarely successful. High-dose IVIG are really helpful mostly for autoimmune cytopenias, but not much for the other manifestation of autoimmunity. Cyclophosphamide is actually the treatment of choice in case of vasculitis. Patients with inflammatory bowel disease may benefit from TNF inhibitors. JAK inhibitors are being used increasingly in patients, especially in patients with some kinds of immune defects that come with elevated function of JAKs. And replacement therapy is important, especially if you're dealing with hypothyroidism. In this case, not only you need to, if possible, suppress the autoantibody response, but you need to replace the thyroid hormone that is not being produced. Now, keep in mind that every time we use these immunosuppressive agents, we know what we do because we need to treat the autoimmune manifestations, but we are also aware that we are posing the patient at higher risk of infections. And especially if you're using multiple agents at the same time, there are some infections that have to be absolutely surveyed. And among them are the JC virus, which is a cause of PML, and the BK virus, which can be a cause of actually very severe hematuria in these patients. So on top of any other surveillance, you may be asked actually to do appropriate testing also for these viruses.